Okay, great. I got the cue to go. Well, good morning, good afternoon, and good evening, everyone. Thank you for joining us for the second session of the three-part webinar series on the strategic planning to improve surgical, obstetric, anesthesia, and trauma care in the Asia Pacific region. My name is Key Park. I'm a faculty member with the program in Global Surgery and Social Change at Harvard Medical School, and it is my pleasure to welcome you all. 2 weeks ago, we had our first webinar on the current status of the opportunities in surgical system strengthening. John Mira and Nikhil Seth kicked us off with the remarkable story of the global surgery movement and the tremendous progress to date. Liz McLeod highlighted the important accompanying role the Royal Australasian Society of Surgeons has played in improving surgical care in the region. And finally, the two regional directors, Poonam Singh from Ciero and Takeshi Kasai from Wipro, demonstrated their willingness and readiness in supporting member states in strengthening their surgical systems. We had an outstanding panel of country representatives, including some ministers, reporting on their unique circumstances and strategies to overcome these challenges. Well, today, the topic is all about financing. And I'm delighted to introduce the two moderators for this session. Dr. Lubna Samad is a pediatric surgeon from Karachi, Pakistan. On top of being clinically active, she's equally busy as a public health practitioner with the Indus Hospital Network. Importantly, she has played a key role in the surgical plan development process in Pakistan. Her co-moderator is someone well known in the region, Dr. Kiki Moate. He's also a pediatric surgeon in New Zealand and directs the Royal Australasian College of Surgeons Pacific program. He's been an early supporter of the surgical planning process in the region and works closely with a number of Pacific countries. Lubna, I'll turn it over to you now.
Thank you, Key. Again, it's lovely to see so many people here at all time zones from all parts of the world. And we're going to start today's session with Dr. Jim Yong Kim, who will be giving the opening talk. Dr. Jim Kim is the Vice Chairman and Partner at the Global Infrastructures Partners. He served as the 12th President of the World Bank Group. Before joining the World Bank Group, he served as the President of Dartmouth College and held professorships at Harvard Medical School. He is joining us by video link today.
Hello, everyone. Thank you for attending this important event on strategic planning to improve surgical, obstetric, anesthesia, and trauma care in the Asia-Pacific region. At every stage of my career, including in 2014 when I was at the World Bank Group responding to the Ebola outbreak, I've witnessed time and again the importance of building robust health systems that are resilient to external shocks and threats. Today, we see that countries with strong health systems, science-based leadership, and experience with previous pandemics, many here in the Asia-Pacific region, have suffered far less economic impact from COVID-19. Moreover, in my last year at the World Bank Group, we began the Human Capital Project, based on research that taught us that investments in health and education were among the strongest drivers of economic growth over the past 30 years. Health system strengthening, if done effectively, can directly support economic growth and help lift people out of poverty. Surgical care is a critical component of health system strengthening. It's the treatment for a third of the global burden of diseases and covers a broad range of categories including maternal and child health, infectious disease, and non-communicable diseases. Investment in surgical care saves lives, prevents disability, and boosts prosperity. Surgical care at the district level has been shown to lead to as much as a 10-fold increase in economic activity. The cost of increasing surgical capacity by 2030 is not small. An estimated investment of $350 billion is required worldwide. But compare this with as much as $12.4 trillion in lost GDP in low and middle income countries if we do not invest in essential surgery and care. We still have a lot of work to do in building surgical capacity. 5 billion people lack access to safe and affordable surgical care. I urge governments, funders, intergovernmental organizations, and civil society representatives to work together to mobilize the necessary investment for surgical system strengthening from a range of domestic and international sources. It's not only a matter of feasibility or cost effectiveness. The fight for surgical access is fundamental to ensuring basic human rights and an abundant shared prosperity. Today we're at a crossroads. The COVID-19 pandemic has humbled us all and shown us that the only way out is to form partnerships that can deliver on pandemic response and on building the kinds of health systems that will protect us from future threats and also provide surgical care to the 5 billion who lack access so we can get back to work. I was born in the Republic of Korea, so I've been very proud of the way that so many countries in the Asia-Pacific region have responded effectively and, more importantly, demonstrated the spirit of solidarity in their pandemic response. Keep it up. Thank you for being part of this important discussion. I look forward to hearing your conclusions, and I will continue to support your efforts going forward.
Right, and now over to Dr. Blake Alkire, who is a head and neck surgeon at Massachusetts Eye and Ear. He's the fellowship director at the Program in Global Surgery and Social Change, as well as an assistant professor at Harvard. His research focuses on developing models to assess the economic costs and benefits of surgical interventions in low and middle income countries. His research has contributed significantly to the Lancet Commission on Global Surgery, the Lancet Commission on High Quality Health Systems, as well as to the Disease Control Priorities, 3rd edition. Dr. Blake Alkire.
Okay. Please let me know if you are unable to see my screen. First of all, thank you so much for having me. My name is Blake Alkire, and it really is an honor to be able to present to this unbelievably distinguished audience today. Today, I want to talk about what we know about the macroeconomics of global surgery. And forgive the nerd in me. I hope it's okay if we begin with a brief methodological discussion, primarily for the purposes of providing a framework for how we can think about the results of global surgery macroeconomic impact assessments in the past, and how we can frame future economic impact assessments, and begin to think about making a case for a broader return on investment for investing in surgical care. So just briefly with the basics. I wanted to start by clarifying that what we're not talking about today is cost effectiveness analysis or cost utility analysis. We're really going to focus on economic impact assessment, which is interested in the consequences that disease and injury have on our economic well-being. Ultimately, these studies don't compare the effectiveness of different interventions, and therefore can't be used to inform resource allocation in isolation. So why do these kinds of assessments? Well, they can answer a number of potentially important questions that stakeholders, policymakers, and donors are interested in. For example, what is the macroeconomic cost of a disease to society at a country or global level? What effect might a disease or diseases have on a country's future economic growth? And what about the potential economic return on investment if a country were to reduce premature deaths by investing in a national strategy to eradicate a disease? So moving on briefly to theory and approach, I'd like to discuss how we think about actually doing economic impact assessments. So let's begin by introducing the concept of economic welfare, which is interested in assessing the overall standard of living or general prosperity of an individual or a group of people. According to this theory, our economic welfare depends upon our ability to consume goods and services, such as food, housing, and education, do what we want to do in our spare time, and our overall health status. All of these components contribute to our overall well-being or economic welfare. To be able to perform economic impact assessments, we need to place a monetary value on how disease impacts some or all three of these components. But this is complicated by the absence of a market-based pricing mechanism for things like leisure time, doing what we want to do in our spare time, or valuing our health. Since we're taking a macroeconomic perspective, the economic disease of marketed goods and services, so for example, food bought in a formal market, or labor prices, these can be assessed in relation to gross domestic product. However, when we think about leisure time and health, we aggregate these components into something called social welfare. Ultimately, if we aggregate the monetary value of market economy and social welfare, we arrive at something called our total economic welfare. So a brief detour into the question, what specific mechanisms does ill health directly or indirectly affect our economic welfare? So when we're looking at the market economy, there is really good evidence that disease and injury impact GDP through multiple channels, including labor supply, education or human capital, and our ability to save and invest, among others. Just thinking through this as a broad oversimplified example, we know that education improves labor productivity, which along with the ability to save and invest has a positive correlation with GDP. Disease and injury can directly limit educational achievement, which affects labor productivity, and it can also directly impact the labor supply. Finally, disease and injury also impact our ability to save and invest through out-of-pocket health expenditures, and by affecting our ability to work and make money. For the components of social welfare, I think it's fair to say that it's somewhat intuitive that disease negatively impacts our health, and also our ability to be able to do what we want to do in our spare time. Now, one more brief detour. If there's not a formal market for assessing leisure time or overall health status, how do we begin to think about placing a monetary value on these components of our economic welfare? To do this, economists rely on a concept known as the value of a statistical life, which I will refer to as VSL going forward. At the core of the VSL is determining how much individuals or a society is willing to pay to reduce their mortality by some small percentage, and then converting that figure into the value of a statistical life. So illustrating through a really simple example. As stated previously, the VSL is best understood as the trade-off we make between wealth and our mortality risk or probability of survival. For those with an economics background, this is meant to represent an individual's indifference curve between wealth and probability of survival. But don't worry if you don't know what an indifference curve is, because it's not necessary for understanding the main takeaway. So let's presume an individual is willing to pay $6 to reduce their chance of dying this year by 1 in a million. Their VSL in this case is approximately $6 divided by 1 in a million, or $6 million. Now, it's really important to imply a few things. Number one, this does not imply that an individual's life is worth $6 million. Life has infinite value. But what it does imply, actually, let me back up. This also does not imply that an individual would pay $6 million to avert certain death, or that they would accept $6 million in exchange for their mortality. But the way to think about this is that it does imply that 1 million similar individuals would together pay $6 million to eliminate a risk that would be expected to randomly kill one of them in a year. All right, so let's move on to the second portion of the talk. I'd really like to discuss how these concepts can be applied using examples from the Lancet Commission on Global Surgery. I know everybody here is familiar with the Lancet Commission, and today we're really going to focus on the macroeconomic key messages. So I helped lead the macroeconomic modeling group, and our primary objective was to estimate the global macroeconomic burden of common surgical diseases using two distinct economic approaches. The first approach we termed the value of lost output, and it examined global market economy losses, so the market economy, from 2015 to 2030, using a model from the World Health Organization known as the EPIC model. Now, don't want to get overly technical. I know I'm on the border already, but the easiest way to think about the EPIC model is that it relates a country's economic output with something known as capital stock, which is the value of fixed investments in a country, such as infrastructure, roads, buildings. It also relates economic output to labor supply and technological progress. So what the EPIC model ultimately does is, based on the Cobb-Douglas function, allows us to assess how a specific disease or diseases affects the labor supply and capital stock at the country level over time, and then therefore how these impacts affect potential gross domestic product. The model is complicated. There's a lot of external econometric inputs. And if anybody has questions about this, please reach out to me afterward. We turn the second approach to the value of lost welfare. This model estimated the global total economic welfare losses due to surgical disease for just 1 year. We've already discussed VSL, and I don't have much to add conceptually, but again, would be happy to talk about the concepts behind the VSL, including how we think about income and health, age, geography affecting an individual or a country's VSL. So this slide is the most important slide for the background into thinking about how we assess the macroeconomic burden of surgical disease. It's a final overview of our two models. For each economic approach, we modeled 5 diseases that represent the vast majority of surgical mortality: neoplasm, injury, maternal and neonatal disease, and digestive disease. Data were available for 128 countries for the value of lost output, or EPIC model, and 175 countries for the value of lost welfare model. So starting with the value of lost output model, or EPIC, or market economy losses. This graph represents the total global GDP losses due to the 5 surgical diseases I mentioned previously from 2015 to 2030. The x-axis represents time. The y-axis on the left corresponds with the blue bars and represents annual GDP losses. And the y-axis on the right corresponds to the red line representing cumulative GDP losses. But really the major takeaway we've already heard, which is that low and middle income countries risk losing up to $12.3 trillion from 2015 to 2030 if no additional investment is made into surgery and the status quo continues. So continuing on with the value of lost output model, this graph compares the annual loss in GDP as a proportion of total GDP by World Bank income classification on the y-axis, and time is again on the x-axis. The key takeaway here is that low and middle income countries, represented by the blue and red lines, will suffer most from surgical disease and stand to lose up to 2% of GDP by 2030. Now, this number has proven to be among the most impactful, and I will say that I think this is due to the fact that one of the most cited and durable economic burden studies in global health was led by Jeff Sachs as part of the Commission on Macroeconomics and Health. And at that time, Sachs and his co-authors estimated that countries with high levels of malaria had 1.3% slower economic growth than those who didn't have higher burdens of malaria. This study is almost 22 or 3 years old, and it continues to be cited on a regular basis. So we think that this 2% number is actually quite impactful. So narrowing down to region, this is still focusing on value of lost output or market economy losses. And again, we're looking at losses in GDP as a proportion of potential GDP. This time on the x-axis, however, we have the global burden of disease, or IHME regions. Unfortunately, we did not undertake a sub-analysis with WHO regions, but the loss in GDP seen on the y-axis is estimated for 2030. So let's really drill down on the correlation or the correlate regions from the global burden of disease study to the audience we have today. So if we look at Southeast Asia, South Asia, and Oceania, we see that there is a risk by 2030 in Southeast Asia and South Asia of about a 1.5% loss in potential GDP, whereas in Oceania, it is significantly elevated to about 2.5% potential risk of GDP loss. Transitioning to the value of lost welfare model, this graph on the y-axis represents the World Bank income group, and on the x-axis we have total economic welfare losses represented as an equivalent proportion of GDP. When we examine all 5 diseases, high-income countries actually stand to lose the most, but that's partly a function of the role that income plays in deriving VSL. However, when we remove neoplasm from the equation, we again find that low-income countries are affected most. As everybody here knows, neoplasm has historically been overrepresented as a cause of mortality in high-income countries, and with the ongoing epidemiological transition, we can expect LMICs to carry more of the weight of the neoplasm burden as well. Ultimately, we found that in just 1 year, low and middle income countries stood to lose $4 trillion due to surgical mortality. My time is up, but I did want to mention that we have a number of other both EPIC-based and VSL studies that augment the evidence base for the macroeconomic impact and burden of surgical disease, and I'd be happy to refer any references. I will also say that for every one of these studies, we have country level results. And so if anybody here is interested in those country level results, they're available in an appendix, but I'd be happy to share them with any of you. So thank you again for having me, and it was an absolute pleasure to be able to be here with you tonight.
Thank you so much, Dr. Alkaya. That was very interesting, and I think it provided many of us an introduction to some of the key concepts on the macroeconomics around global surgery. Thank you for that. And if there are any questions, please feel free to type them into the chat group, everyone, and we'll try and incorporate them into the discussion as we go into the second half of the discussion. And from here, I would now like to introduce you to Dr. Rifat Atun, who is a professor of global health systems at Harvard University and the faculty chair at the Harvard Ministerial Leadership Program. He previously served as a member of the executive management team of the Global Fund as Director of Strategy, Performance and Evaluation. Professor Atun has advised more than 30 governments on health policy and health system reform and has worked with the World Bank, the WHO, and other leading organizations such as Medtronic, Merck, Novartis, and Hoffmann La Roche. And today he's going to be joining us via video link.
Hello, I'm Dr. Rifat Atun. I'm Professor of Global Health Systems at Harvard University. It's a real pleasure to contribute to this joint UNITAR Harvard University event on the strategic planning for surgical, obstetric, anesthesia, and trauma care in Asia Pacific. My presentation is going to focus on fiscal space. So there is a compelling case for investing in surgical, obstetric, anesthesia, and trauma care. But where will the financing come from? There's a critical need to create fiscal space for health. Creation of fiscal space is one of the targets for Sustainable Development Goal 1. In fiscal space analysis, one would typically look at 6 areas where potentially new sources of financing could come from. The first is conducive macroeconomic conditions. With economic growth, there's an opportunity to generate more revenues and invest this in health, as has been done in Brazil, Turkey, and Germany, for example. The second area is reprioritization of health within the government budget, allocating a greater proportion of the public budget to health sector. Of course, this is not easy, as other line ministries will also request funding for their areas. But a number of countries, such as Turkey and Mexico, have been able to do that very successfully with excellent outcomes. The third is sector-specific domestic revenue sources, essentially targeted taxes that can be allocated to health. For example, tobacco tax, which has been successfully implemented in the Philippines and Thailand. In the Philippines, funding was used to finance expansion of universal health coverage, and in Thailand, funding has been used to invest in prevention. Fourth is international finance, borrowing to invest in health. And with COVID-19, number of countries have been able to borrow at concessional rates to invest in health. For example, Argentina and Nigeria are good examples. Fifth area is improving health budget effectiveness and efficiency. That means improving the functionality of the health system to achieve greater equity, effectiveness, efficiency, and responsiveness. And a number of countries have been introducing priority setting mechanisms to achieve that. Good examples include the UK, Malaysia that has introduced health system reforms to target NCDs, and Thailand that has introduced health technology assessment. And finally, innovative financing. And I shared with you the paper we published recently on innovative financing for surgery. And there are many opportunities in this area. And we've seen recently increasing use of social impact bonds, for example, in Australia and India to finance specific areas in health. Each of these areas provide an opportunity to expand the fiscal space to invest in improvement and expansion of care for surgery, anesthesia, obstetrics, and trauma care. Thank you for your attention.
Thank you. And now I think I'd hand over to Dr. Maute to introduce the panelists for today and take us into that section of the talks today.
Thank you very much, Lubna. Good on and greetings everybody from around the world, and particularly to our Asia Pacific teams and people. Nice to see everybody here, and also to the previous three speakers. Thank you for the conversation. The next set of speakers, I'm going to ask them to provide a 2-minute overview of what they do. And then I have pre-warned 1 or 2 of questions that will be asked, and probably 1 or 2 more. And then we'll open it up to for discussion, and Dr. Lubna and I will moderate that. So without further from me, I'll ask Dr. Peter Cowley from WHO Wipro office, who coordinates the health policy and service design, to say a few words.
Thank you very much. And it's indeed my pleasure to be part of this seminal event. I'm going to start with some figures. We all know about the economic decline associated with COVID-19, but the figures are quite astounding. We're talking in terms of GDP growth in the region, the decline in GDP growth in South Asia, a negative 3.9%, Pacific, negative 5.4%, Pacific, negative 6.6%, South Asia, negative 5.4%, and the developing parts of East Asia, negative 3.9%. Why should we be concerned about this? Because money from government, for government, comes from economic activity. It comes from VAT receipts, income tax, social health insurance contributions, et cetera. The actual declines in government revenue take are not exactly matched with the declines in GDP growth, but they resemble them. So we call that a revenue shock. This is deeper and it's wider already than, in terms of time, than what we've seen with previous crises, the monetary crisis, which developed many parts of Asia in 2008, 1998, 1999, and then the subprime mortgage crisis, inspired crisis of 2008, 2009. This one's much worse. It's deeper and it's wider. The government is also impacted by increased expenditures related to COVID-19. This makes the fiscal space challenging, to say the least. Most countries in the region will see either a best case scenario in terms of Ministry of Health budgets on a per capita basis. If you compare essential healthcare to essential healthcare, to rip out the COVID-19 health expenditures, you're looking at either a decline, if you're lucky, a stagnation, if you're very lucky, a slight increase on a per capita basis. However, this increase would have been nothing like what its trend line had been previous to COVID-19. How does this impact essential surgery? Well, the government revenue has shrunk. So the percentage that goes into health is traditionally around 6 to 11% of government revenue goes into health. The only way that on a per capita basis that the health budget is going to increase is that it gets a larger percentage of government revenue. So, for example, if it used to get 8%, it's going to have to go up to 9%. It's going to have it. Now, this is going to be even more challenging because COVID-19 vaccination is going to be rolling out. And that's going to add on, if your government was spending 8% on health prior to COVID, during COVID, now some governments it's going to have to spend 8.5 or 9 just to get COVID-19 out the door, vaccination out the door. So it's very challenging out there. And one bright light in terms of essential surgery is that there's been huge investments in increasing ICU and in particular, respirators. A lot of respirators have been purchased, and particularly in many parts of Asia, huge numbers, many of them through multilateral bank assistance. And this could be an average point in terms of improving essential care. Of improving surgical care, because there's a lot of capital that's being moved, especially mid last year. And this is an opportunity as well. Over.
Thank you, Peter. We'll come back to you for some thoughts around that. To the next speaker, the panel, Dr. Ahmed Abdo Ahmed, Senior Global Health Specialist from the Islamic Development Bank Group.
Yes, thank you, Mauti. Indeed, it's a pleasure to be with you, all of you here today, this morning. Good morning, good afternoon, and good evening, depending where you are. Indeed, the bank is working in Central and Southeast Asia. For those who didn't know the bank, we have all the CIS countries, the Commonwealth of Independent States in Central Asia are our member countries, and most of our Southeast Asian countries. And the particularity of and specificity, let me say, in our investment that we have undertaken over the past 40 years in the Asian countries, if we took the CIS countries, the Southeast Asian countries, but also the GCC countries, because they are also part of Asia. So most of the investments were channeled toward the tertiary levels, so the hospitals. And we have noticed that these investments are overcoming what other MDBs have invested so far, even the Asian Development Bank. In terms of proportion, we were excelling in this level. And most of these reports were targeting the specialized hospitals. So all the 5 areas that you have highlighted and in the presentation that we have seen. So I will not come back to the importance of investing of health, as President Jim has highlighted the importance. However, actually, we are trying to redirect our support from the tertiary level to the primary health care. And that's the reason why actually the bank's health policy is more driven towards the primary health care. But primary healthcare, it doesn't mean canceling all the surgical aspect. Yes, because we have adopted and somehow inculcating the DCP3 and mainly all the surgical activities related at the primary level. This will be some the best buy interventions that have been selected under the DCP3 third edition have been adopted by the bank. And actually, we are looking to 3 main strategic objectives actually. The first one that we are looking into it is leaving no one behind. And I know that this theme has been used by many of us or sisters MDBs, but actually we are targeting to expanding the access to universal health coverage package to the poor and the most vulnerable, not only in the low-income countries or the lower middle-income countries, but also, as you know, we have always a pocket of poor and vulnerable people, even in the high income countries that we have in the higher middle income countries. And the second objective is looking into strategic objective is to providing access to safe, quality, and equitable healthcare services at the community level, because there are some activities related to the surgery that could be undertaken. And as one of the speakers has highlighted, that we could reduce many of the mortality and the morbidity at this level. The third one is we are trying to address the issue of the universal health coverage through establishing the social health insurance. And thanks to Professor Atun Rifat, who has highlighted how we could support this mechanism. So, and also we are looking into increasing the innovative financing, and this the banks, I could here highlight one of our big support that we are undertaking jointly with the Bill and Melinda Gates Foundation, but also with the Abu Dhabi Fund for Development, King Salman Humanitarian Center, Qatar Fund for Development, and actually UK DFID has joined us. We call it the Lives and Livelihood Fund. And so we are providing some concessional financing to the member countries and those who are caught by the IMF conditionalities. So we are rendering the loan concessional by providing them up to 35% grants financing. So them for to achieve this one. The second thing, we have a very good experience in Pakistan under the triple win financing it was used for the polio eradication, but we have also other facilities like the public-private partnerships to support the big specialized hospital in Malaysia and mainly in Turkey also. And actually, we are under discussion for Kazakhstan and Uzbekistan and all the GCC countries. I will not go into this detail. The other aspect that we shall not forget is the COVID-19, the reality of COVID-19. So we cannot forget this aspect. So we are also targeting one of our strategic direction is to consider the One Health approach. So the animal health, the human health, but also the environmental health. And finally, we are looking into building the capacities of our member countries in terms of training, and using the different modes, the different ways and means to improve the capacity of the human resources in our member countries. So I will stop here for now. Thank you, Mawati.
Thank you, Dr. Ahmed. Okay, I've allowed that to go on for two reasons. One is for the next set of speakers because of the time. We need dialogue to go with our membership. Dr. Ahmed's actually covered quite a lot of issues in that moment. So I think in terms of what we look at, COVID, health finance, and partnership private, if that's included in your systems that you're going to talk about, then I just want us a reference because I want us to get through the next 8 speakers that's been covered, and then we can come back because the countries, I think, know what you can provide, but I think the countries need to know the mechanisms and how we go about that. But thank you very much for that comprehensive coverage. So I'll ask Ms. Peggy Say to say a few words, upstream officer at the International Finance Corporation for the World Bank Group. Thank you.
Thank you, moderator, and greetings everyone from London. And it has been a pleasure to join this forum together with a lot of the distinguished scholars and also thought leaders in the field to discuss this very important and urgent issue. I am Peggy and I work at the upstream unit at IFC, which is a new unit in the organization that works on project incubation and early stage development together with public and private sector. So I really come to here to share some of the frontline experiences and on the ground projects that IFC is doing related to today's healthcare topic. And health sector has always been a priority sector for IFC, which becomes more important than ever after the COVID-19 pandemic happens. And our focus is really on the affordability aspect, the accessibility and safety aspects in the healthcare system, which I think Dr. Kim has also alluded to. All these important factors would link to the quality of human capital in the country. And so from my experience at IFC, we believe that private sector participation is essential, has an essential role to play in this equation. And there are a lot of significant funding gaps that we have observed in the sector that requires development finance institutions like IFC to come in and support. So that's why we have developed a broad suite of financing tools and also advisory tools to support private sector to work together and work more closely with the governments to deliver quality healthcare to the population. And our role at IFC is really to assess the bankability and to improve the commercial aspects of healthcare projects so that we can really translate the social impact of all these meaningful healthcare projects to economic benefits, and then can mobilize and make a business case for more investors to come in and get interested and actually invest in these projects. So here we are establishing strong links between patients served to public and private healthcare reimbursement systems or mechanisms so that we can really improve the resilience and improve the entire healthcare infrastructure. So we understand that to figure out, there's no like perfect healthcare system. And so we need some time to figure it out, and it can be a messy process, but IFC would be supporting a lot of these like committed private sector companies who would like to do this, and we would take on the lessons learned and share it across the region so that more successful models can be replicated in different markets. So to end my introduction, I would say IFC, we are here to target ambitious and first of a kind projects in healthcare and improve their bankability and commercial viability. And then these can be developed as demonstration cases and examples in emerging markets so that, or in healthcare, so that more of these investments can be crowded in and really to achieve the goals that we are discussing here today. Thank you.
Thank you, Peggy. If I can introduce Dr. Do Hae-Young Kim, Health Advisor for the Korean International Cooperation Agency, to please take the floor.
Thank you, Dr. Mao-Wait. Good morning, good afternoon, and good evening, everybody. I'd like to say hello to all of panelists and attendees. This is Do Hyung Kim from Korea International Cooperation Agency, KOICA. It's my honor to join this meaningful session today. I'd like to share KOICA prospect of surgical care briefly. Next slide, please. Since 1991, KOICA has been implementing ODA project in the countries where 44 country offices are located. In the Asia Pacific region, we have 14 country offices. In 2017, President Moon declared New Southern Policy and Korea-ASEAN Future Community Initiative was started. Along with this policy, the amount of Korea's ODA in Asia also increased from 37% in 2018 to 38.8% in 2019. KOICA also updated regional strategy to support ODA in Asia in accordance with the government's policy, which includes Vietnam, Cambodia, Laos, Myanmar, Philippines, Indonesia, where KOICA's country offices are located, as well as Uzbekistan and Mongolia in Central Asia. You can see the table, which includes the number and budget of KOICA's health project over the past 4 years in the Asia Pacific region. As you see, the scale is increasing. This trend is expected to continue in the future. From the health sector strategy aspects, KOICA is striving to provide quality healthcare services and to ensure universal health in partner countries. Especially regarding the surgical and obstetric care, KOICA aims to contribute to the achievement of Sustainable Development Goals by providing high-quality maternal, newborn, and child health care services, and hope to decrease deaths from preventable disease. Through this, KOICA will contribute to reduce maternal mortality ratio, SDG 33.1.1 indicator, and under 5 mortality rate, SDG 3.2.1 indicator, etc. And for this, surgical and obstetric efforts or care interventions will be needed. Next slide, please. So here are two project cases. Although Tanzania is not located in the Asia Pacific region, I think this kind of a project could be applied to the project in Asia Pacific as well. Through this project, KOICA is establishing health centers satisfied with the criteria of CMO, Comprehensive Emergency Obstetrical and Neonatal Care Services, providing necessary equipment, training medical professionals, and strengthening national blood transfusion system. Another example is the Korea-Uzbekistan Friendship National Children's Hospital project. KOICA provides advanced surgical skills improvement training for medical professionals in hospital and develop clinical pathway. In addition, by building a training center, we are supporting the Uzbekistan government to strengthen their capacity with ownership in the midterm to long term. Through this project, we expect not only reducing mortality and morbidity rate, but improving the quality of care. Here is the end of KOICA statement. Thank you.
Thank you very much. Thank you. And if I can please ask Professor Tanaka Go to give us some words. Executive Technical Advisor at the Human Development Department for the JICA, Japan. Thank you.
Could you show the slide for me? Yeah. Okay, good. So thank you very much for inviting me, JICA, for this special symposium. And this is very important, and think about strategic planning to improve surgical and trauma care. So I'll introduce some topics which JICA is doing in West Pacific region. Next slide, please. So our strategy is based on the JICA's initiative for global health and medicine. Because our strategy is based on the health and medical system to achieve human security 2.1, 2.0, and the universal health coverage through developing health infrastructure in combination with soft components of cooperation based on Japan's experiences. So last year at the UN General Assembly, our Prime Minister Suga stated that for leaving no one's health behind, one pillar is development of therapeutics, vaccine diagnosis, and work towards ensuring fair and equitable access for all. And secondly, building hospitals through providing equipment and supporting human resource development. And thirdly, measures towards a wide range of issues such as water, sanitation, nutrition, education, and urban planning. So based on our Prime Minister's statement, we set up the 3 pillars of actions. And today's, I think, put importance on the pillar 1, strengthening treatment systems. So firstly, constructing core hospitals where people can receive necessary treatment safely, providing rehabilitating medical equipment, and developing capacity of medical professionals. We are thinking about try to, provide or newly establish or rehabilitate about 100 hospitals around the world. And secondly, we are strengthening ICUs because of the new coronavirus. I think the intensive care is quite important for the patient who. So we try not to people die because of new coronavirus anymore. So we are trying to networking hospitals and utilizing digital transformation, including remote medicine. So throughout Asia since 2008. We put this kind of amount to for building hospitals. So it's totally for grant aid around 513 million US dollar, and the yen loan for 774 US million dollars. We have 28 grants and yen loan 5 cases. But because most half of the this grant and yen loans go to Southeast Asia, so we put very much importance to South Asian countries. So through in the parallel with the Pillar 1, we are also promoting enhancing ID research and our system, like the research institute, building up the research institute, and thirdly promoting ID prevention, including education and urban planning. Next slide, please. So I want to show the example of our assistance to health sector in Mongolia. So we're, as a Harvard, we built up the Mongolia Japan Teaching Hospital as a grant aid. It cost 80 million US dollar, and it opened 2019. We constructed the first universal hospital in Mongolia with advanced medical equipment, including Japanese design. So this function, we put importance on surgery and gynecology and the emergency and ICUs. So it includes 104 beds. But we want to, we are very put importance to, go parallel with a soft amount. Amount is not so that big, just 5 million US dollar, but our project for establishment of hospital management and medical service at Mongolia Japan Teaching Hospital, as a technical cooperation. It started 2017 to 22, and the importance is we got support from our Japanese universities, hospitals. Like we put this case with Tokushima and Ehime University are supporting very much with JICA. So it's technical cooperation for appropriate and sound management, including financial human resource and providing patient-centered medical services. We are aiming at comprehensive system for advanced medical services, including financial human resources development. That's for. Thank you very much.
Thank you, Professor Tanaka. If I can ask Dr. Stephanie Williams, Australia's Ambassador for Regional Health Security, to please take the floor.
Thanks, Kiki. I'll be very brief. So Australia, through the Department of Foreign Affairs and Trade, works to support the improvement in health systems and health security in our region and globally. And relevant to today's topic, I think we're asked to briefly talk about what we do. If we're going to describe our priorities, it is supporting countries progress towards universal health coverage and reducing our risks from health security threats. Relevant to the financing of surgical care and how we make a better case and access development dollars to do that, there are 3 examples I wanted to give. The first is through a multi-country regional project Australia through DFAT has with the World Bank under a trust fund called Advance UHC, which is focused on dot number 5 of the professor's presentation from before about how we can work with countries to improve the quality, effectiveness, and efficiency of their health expenditure. It's through that, I think, is a huge opportunity to expand the scope of expenditures that Australia can support with the World Bank as our lead partner in countries with country health systems. But it isn't just about financing. And the 2 other things I wanted to mention was our long-standing commitment to the workforce quality improvement. And I know that was probably the subject of yesterday's panel, but through our long-standing partnership with RACS, with SPC, and with FNU, we have again committed to multi-years of improving mentorship training and access to specialty services, surgical services in the Pacific. And the last current example of how we work to support the topic of today's presentation, today's seminar, is through our long-standing regional and country partnerships for sexual and reproductive health and rights. So on the obstetric side, upstream in prevention, in working to make sure adolescent girls in particular have access to contraception and women have access to the things they need to ensure safe delivery and safe pregnancy. I look forward to the panel discussion. Thanks for the floor.
Thank you, Stephanie. If I can ask Monique Werbenhorst from USAID as a previous senior advisor in global health. Monique, the floor is yours. Thank you.
Great, thank you so much. And it's a real privilege to be here in my former role as actually I had moved up to Senior Deputy Assistant Administrating Global Health and really had a lot of opportunities to really try to push the agenda, push the envelope at Global Health for safe surgery care and anesthesia care. I'll talk very briefly about what USAID was doing up until very recently in the area. So traditionally, I think one of the issues with funding of surgical care, at least from the development agency perspective, is that the development agencies such as USAID are still to some extent focused on a view of global health that is comprised principally of infectious disease, maternal child health, and nutrition, kind of the same types of priorities that we were focused on back in the 1960s in a way. We have in global health at USAID has really come on board though within the last, I would say, 2 years to begin to focus on surgery in an intensive way through a suite of awards that are called Momentum in all caps. And what Momentum does is it focuses on cesarean surgery, a cesarean delivery, childbirth associated hysterectomy, for example, when you need to do a hysterectomy for intractable postpartum hemorrhage or hysterectomy for placenta accreta or any one of those other types of complications. In addition, USAID also funds surgery for trachoma, blinding trachoma, and also for LF, lymphatic filariasis, surgery for hydrocele. So there are some surgical emphases, again, through this specific suite of maternal child health intervention Momentum, as well as some of the infectious disease ones as well. I do have to say that with COVID-19, one of the earlier panelists, and I apologize, I don't remember exactly who it was, brought up the question, the situation that there's been a very intensive push to improve ICU capacity, critical care capacity in the developing world, including a focus on ventilators, focus on provision of oxygen. And that has had its challenges, but I think that there are ways in which that particular set of emphases can be built upon to try to strengthen the future of surgical care. Just a couple of other ideas. You know, one of the things that we were very involved with at USAID was private sector engagement. If you look at the size of capital markets globally versus the size of the development sector is billions, the capital markets are trillions. And so I do think that private sector engagement is going to be the wave of the future. Many countries are getting out of the development business. Countries are scaling back very rapidly. And if you look at global development agency spending over the last really 5 to 10 years, it's really plateauing and flattening, even for our infectious disease initiatives. So I do think that there's a need to begin to look at those private markets, look at the philanthropic market, the philanthropic and charity market, philanthropic and charity sector in the United States. The funding envelope for that sector surpassed the U.S. defense budget, the entire U.S. Government defense budget in the mid-90s, and has just continued to grow. So I think that those are some of the opportunities. There has been some really excellent discussion by our colleagues in the economic and financial sector on innovative financing mechanisms. One of the most important of these is revolving capital funds and other types of capital funds and investments to enable facilities and hospitals to acquire the capital they need to improve infrastructure. With COVID, just as one tiny example, this has been a huge issue. USAID worked extremely hard to try to get oxygen out into the field. And apart from the issues around oxygen, it's almost like a cartel. There were problems with oxygen piping. And this is an issue in the Western Pacific region, number one, because it's such a far-flung region. Number two, a lot of the infrastructure is decades old. And so in order to begin to improve infrastructure in different areas, there is a need to make capital available to the actual health facilities so that they can, when they need to make those types of large-scale improvements, they can do it, as well as to expand staff and so on and so forth. One final thing I want to bring up is that we are very accustomed to thinking in terms of the public sector, where when you look globally, a significant proportion of care, if not the majority of care, is provided by the private sector and by the voluntary and faith-based sector. This is something that I think we really do need to keep in mind, because the trajectory of health systems is that as countries become wealthier, citizens tend to seek care outside of the public sector and want to move into the private sector. And so I think engaging with local organizations, especially those that own networks of hospitals, networks of clinics, is a way to begin to cause this to be more of a grassroots, bottom-up approach to expanding surgical capacity in the developing world. I do want to commend the PGSSS for its incredibly strong work in getting the NSOBs put into place. And I think that those are important. I think that they're critical. But at the same time, I do think that we need to also continue to have a focus on local partner engagement and the private sector and voluntary sectors as well. Thank you.
Thanks for that. If I can ask Ani Shrestha to say a few words, Executive Director from the Nick Simmons Institute, and you're based in Nepal, I think, I know. The floor is yours.
Yep. Thank you very much. It's a great honor to be speaking today in front of this August gathering, and I'd like to thank the organizers. Briefly, I'd like to say a few words about the Nick Simmons Institute. It's a family-funded philanthropy based in the US, but we are in Nepal now, and it was founded by Jim and Marilyn Simmons in 2006 to honor their son, Nick, who came to Nepal, loved Nepal, wanted to become a doctor, and wrote to his parents saying that he would like to spend a couple of years in Nepal after he becomes a doctor. But unfortunately, he died on a trip to Indonesia. So in his name, his parents, Jim and Marilyn, founded this organization. That was in 2006. At that time, what is unique about this organization, this philanthropy, is they gave a blank check and a blank piece of paper to the people of Nepal. There's some group here who said that, okay, you decide what you want to do and decide how much you want. I think this is a very unique thing of any philanthropy. And the people here in Nepal, they discussed, they got together and they thought, okay, what to do? There were a lot of back and forth on what to do. And they decided, okay, we're going to support the rural health. We would go into the curative health, and we would be a supporter of the system. We would not be building a hospital or something like that. We'd support the government. So that was the aim then. And at that time, what they saw was at the district level hospitals, there were roughly around 90 hospitals. There, only around 10 or 15 hospitals had a functioning OR. That too, it was not doing 24/7. It was off and on, and they were not functioning well. So seeing that, they realized, I mean, the people who started it, it was all Nepalese. I mean, the idea came in by the Nepalese people over here, and they said, okay, we're going to support these hospitals. And what they saw then was there was a big deficit in the HR. The health workforce wasn't there. The enabling environment wasn't there to function well. So we supported that. And at that time, we supported only 3 district hospitals. We supported and in fact, as in any developing countries or even the developed world, I think nobody would want to go into the rural areas, and giving them incentives and those sort of things, and also providing training. So our focus was on training, and training on not the high-level doctors. So we had our own program called Anesthetic Assistant. It was a 1-year program, and they all were deployed in these district hospitals. Similarly, we focused on the GPs. Here in Nepal, the GPs also perform surgery. They give anesthesia. So they were the replacement of the SOAs that the Lancet Commission was talking about. So one person could do the work of these three people, including the orthopedic surgeon. So it was not only, at that time, the focus was on C-sections, but now they were also performing the bellwether procedures, what Lancet Commission was talking about, like they were doing laparotomies and simple fracture treatment also. So a single person, a GP, could be performing these things. So those were our focus. What I would like to, we have this August gathering here. What I've seen is we were one of the only, or I would say one of the very few organizations that support the curative health. Rest of the EDPs, the bilateral organizations, the multilateral organizations were mainly on the preventive health, and there were very few people focusing on curative health. And I would, in this gathering, I would like to request the other bilateral, multilateral organizations also to give a focus on surgery. Everyone knows this, so global surgery is a stepchild of global health, but now it no longer needs to be a stepchild. I think if we all contribute something in this aspect, I think we can go ahead. Thank you very much.
Thank you, Anil. Thank you for that commentary. If we can ask, last but not least, Mr. Shantakumar Banik-Shalvan. I know you've got legal framework in your mind, but there's not a court case. But I'll give you the floor, and you can give us some comments around the Global Impact Partners as a managing partner. Thank you, Shantakumar.
Thank you very much, Mr. Moate. Is my screen visible?
Yes.
Wonderful. It's a pleasure to speak with all of you today, and I'm very excited about really what the potential is over the next decade of ways we can collaborate between the private sector to advance global surgery along with foundations and multilateral institutions. To give you a quick background on ourselves, and I'll dive into what we do, Global Impact Partners is an institutional impact investment advisory firm with a simple mission. How do we serve people on the planet through mobilizing the capital markets? Now, we cover a number of sectors within this, which healthcare and outcomes-based financing are key ones and relevant to today's discussion. Building on Professor Toon's comments right at the start, where we really fit in is thinking about how do we mobilize external capital to expand the fiscal space, and where is this particularly relevant within global surgery? And one important thing which we also touched on today was the ENSO process. One key thing we've been doing now, collaboration with the PGSSC, is thinking about through this whole ENSO development process and parts of the ENSO, what are ways we can actually identify gaps in funding and opportunities to mobilize capital through this entire cycle. To point to the scale of the opportunity, this is just one chart to indicate this. The pool of asset owner signatories, the UNPRI, has grown from near zero to now 22 plus trillion, who now incorporate ESG issues into their investments. Diving into greater detail, those who specifically then target impact, there's now been an exponential growth. And the most recent Global Impact Investor Network survey found that there's now 710 billion in total assets looking at impact investments specifically, which are investments looking to make a positive social environmental impact. What I'd love to present today is some opportunities to see how we can mobilize some of this and really fix some of these blockages in the system that are currently limiting this flow into the space. I also want to emphasize that I by no means have a panacea to offer. This is not a cure-all, but in selected opportunities and selected ways, this can be a complement of the overall solutions we mobilize to advance global surgery. So one key thing we've been looking at with the PGSSC team is, for example, looking at the investable, looking at the investable aspects of ENSOPs. So when we went through some of the materials within this, we identified that while, of course, the ENSOP as a whole might not be investable, there's certainly aspects both on workforce development, capacity enhancement, as well as equipment purchases and facility investment that could potentially be funded through private sector institutional impact investment. One such framework we have is outcomes-based financing. So one platform we've established is the Global Health Impact Partnership, which is a platform to mobilize $1 billion to invest into improving outcomes-based financing solutions globally into these actual projects. Just to give everyone a quick background of it, there have now been 134 projects done in 27 countries, this outcomes-based financing. And in health, though, there's actually been quite a dearth of projects, which is where I think there's significant growth potential within this. To give you a high-level view, and this is an example of the previous one in Canada, the Public Health Agency of Canada entered into an outcomes contract where they would agree to pay based on improvements in hypertension outcomes across a cohort of 7,000 Canadians. And that basically then mobilized investor funding to then finance the Stroke Foundation of Canada to go out and run this kind of treatment program. One example of program we're looking at, so we're doing this both in high income as well as low and middle income countries. So in Australia, we're working with the Assistant Secretary of Health and 2 state governments, but at the same time working with the Indian and Indonesian governments, is looking at financing precision prevention of cardiometabolic disease and maternal child health through investing into a cohort of community health worker organizations, an AI platform out of San Francisco, developed at Stanford Medical School and Smart Health Technologies to roll out a mass precision prevention program and then monetize a share of the savings delivered to government health systems from downstream cost savings within this. Another key aspect we've been looking at is health infrastructure financing. This could be used both, think of this like the way, infrastructure and asset class has grown exponentially over the last 30 years. And I think it was apt that Dr. Kim, right, is now at Global Infrastructure Partners, where we look to basically mobilize capital into this long-term capital for infrastructure assets. And increasingly what the COVID-19 pandemic has shown us is the importance of social infrastructure, not just hard infrastructure like toll roads, ports and airports. One way this can be done, and we're currently exploring this with an IFC team, Sarvana drawing out of Singapore and healthcare providers in India, as well as Indonesia, is financing the development of healthcare clinics and basically investing into the hard assets of it, and then looking at securing an offtake for that over the next few years and spinning out the real estate to take out a lot of the fixed costs, but even some of the equipment, which can be fixtures within these buildings. But this can also apply for innovative approaches. So one of the programs led by Dr. Kuchel at the Harvard Medical School PGSSC is actually being now exploring in India the use of drones for both delivery of the COVID-19 vaccine as well as blood to support maternal health outcomes, particularly in postpartum hemorrhage, and seeing how we could basically create drone investments for that capacity enhancement and to extend access, because now you're not limited by road infrastructure for this and building on existing programs. So I just wanted to briefly touch on some of these areas, and I'm very happy to dive back more into these in the Q&A. But what I just wanted to highlight is some potential approaches to consider, and we should ultimately think about how do we really solve for this kind of blockage in the system, stopping the over 22 trillion in ESG aligned assets, and to solve the funding gap we're facing, particularly in a fiscal environment where we see this shrinking fiscal space. Thank you, Mr. Malate and my fellow panelists.
Thank you, Shantakumar. Look, I'll be trying to get us, I guess, to get to the stage where we can actually have interaction with our membership on the panel to have a dialogue. And so thank you everybody for the contributions. I guess I did flag at the start, and in terms of this is strategically look at the funding models that we have and the various institutions who have the resources, as well as countries who have the resources, and countries around low to middle income are looking for opportunities on how to approach countries or institutions. And I did flag to say that what are the two most important things that you see in terms of having a proposal come in front of you and you say this is the best thing since sliced bread. And then maybe on the converse is what are the two most irritating things that you may get on a proposal that you would say we need to do a lot more work on this. I'm going to hold you to think about that for a minute, because I think we need to give this opportunity to the floor for people to provide some thoughts or questions for a minute, and Dr. Lubna, maybe some thoughts from you as I look at parking it here for a minute.
Thank you so much. I think this has really been a fascinating breadth of speakers we've had this morning, and morning for me. But I'm going to start off with a very practical question, if I can use that to start the conversation rolling. There is a growing focus on transitioning from tertiary healthcare to universal health coverage with a focus at the primary care level. And this was mentioned by some of the speakers as well. The question that I have is that a good chunk of surgical care needs to be stationed at the secondary level, at the district headquarter levels, at the little short of tertiary care level. How can that reality be integrated into the growing focus on primary care? Because that really is a reality for surgery. As we work through the system in Pakistan, for example, we realized that other than the recognize, stabilize, and transfer component, which is done at, can possibly be done at primary care, the bulk of surgical services happen at secondary level hospitals. And how do we go about strengthening that through the existing financing models and structures that we have in mind?
I think Ahmed was the one that raised that proposal in the first instance. Maybe Ahmed, some commentary on that from you, please. And while we're waiting on Ahmed to come on.
Okay, still, are you hearing me? Yep. Yes. Okay.
Yes.
Yes, thank you very much for this comment. Indeed, what happened, how we are selected, I think this is related more to the selectivity of the projects, because we need to consider first, so before this project comes to the banks as well as for other institutions, it goes through a certain process. We are looking mainly for 2 or 3 considerations, mainly, let me say 3 of them, just to be short. The first one is the relevance of the proposal. So is the project aligned with the country strategy or related with the health strategy of the country, and also the bank's strategy? So this is what we are looking into, and also we are looking to the poverty reduction strategy of the member countries. And we are looking also into what the incidence of this poverty, or if it has not been done, what will be the effect? So if nothing is done. So this is one of the consideration that we are looking into. The second one is to the readiness. The readiness of the project, because we are many times receiving projects that needs to be revamped, or need more information to show how it will be. It shall be mature first, and it shall show effective delivery, that it will be addressing a real context. The preparation level is very advanced, and we have a detailed implementation plan. So this makes it bankable for its eligibility. Then the results also, if it can secure immediate impact, what are the immediate, the midterm and the long-term impact. So these are the in terms of the selectivity of the process. Now, when it comes to the financing, of the proposal, so it will be easily if it fulfill these 3 boxes. So therefore, the bank may consider it for either to go depending on the country's level, for instance, and depending of the priority of the countries, because for some member countries that are middle income countries, are upper middle income countries, we are providing to them more concessionality because of the priority of the subject in the country, or because it's very well prepared. But the importance is where we have noticed that we have invested a lot in infrastructure in some countries, but still the outcome is not that what was expected. And so then we reshape our interventions to the primary health cares. And the primary health cares, as you know, it's including not only the primary health care, but also it's including the secondary level hospitals, the referral level. So they have surgery, they have everything. They have a full-fledged team and equipment that are managing equipment. So this is where we are actually shifting not totally, because we are still receiving bankable project and bankable proposal addressing health issues in our member countries that request the bank to support the tertiary level. But actually, the priority is really shifted to the primary healthcare. And I believe that we have at the global level one interesting tool that we may need to consider as good as the DCP3, which is the Primary Healthcare Performance Initiative. So this is also something that we need into. We may look into it to reshape our thinking, because in most of the countries, the primary health care, so nothing shall be done, just saying it's like just looking to GP and then going to home or be referred to the upper level. But it's not going like this. We have the secondary level, and we may need to reinforce this second line of the health system. Thank you.
Lubna, we have a question here from Mohammed Chowdhury. The question, I'm going to direct this question to Professor Tanaka. We want to strengthen our existing facilities in the public sector children's hospital, especially for neonatal surgery. How to go about it? Professor Tanaka, you have a go first, and I'll ask also the other funding agencies to have a think. And if we can limit our answers to a few minutes, otherwise I will put the timer on because we've only got half an hour to go. Where's Professor Tanaka?
Is it a question about how about the children's hospital? Is that the question?
The question is how to go about strengthening our existing facilities in the public sector children's hospital, in particular for neonatal surgery. So they're looking at the mechanisms of how to approach the financing. What today's about.
Okay, we are actually doing some also the children's hospital rehabilitation program, but we try to do basically on the general teaching hospital is the main target for our hospital rehabilitation program. So, but it depends on the country's demand. If really the cases the country demanding for the children's hospital, but I think so far in Pakistan we are building the pediatrics hospital in Karachi, and some in the Southeast Asian area we have few children's hospital because of the demand of the country. Thank you.
Okay, if I can ask, yes.
If I could interject, we have Minister Wanka from Fiji, who would like to perhaps like to hear from him on how he is trying to build the capacity of hospitals in Fiji to be able to deal with bellwether procedures. Minister Wanka, if you're on the
you know he's just trouble. You know he's just trouble.
Hello, Kiki. Yeah. And thank you. Hey, Mullah. Thank you, Dr. Lubna. Don't worry about him. And also thank you to all the colleagues listening from around the world. Yes, there's a few things I just want to share. Number one is certainly with the challenges that are happening economically, it is a challenge to be able to both deal with the normative functions of the ministries of health and at the same time deliver on the extra normative functions. And, they are either can be COVID-19 or dealing with disasters. From a Fiji perspective, and this is similar to the small island development states and in the Pacific region, we want to be able to carry on very quickly with making bellwether capable facilities as part of the universal health coverage reach that we want to do. And in Fiji, at the moment, we are running 2 extra facilities as bellwether capable. Our vision is to look towards making 5. And there's a few things. We all know that countries such as Fiji are very dependent on the tourism sector. And we all know that after COVID-19, the vaccination and the opening up of borders, there's going to be a lot of challenge on small island development states to show that they have very strong health systems in being able to have tourists and travel happen back into these areas. And I could speak on Pacific Island nations in saying we want to pre-position ourselves to be able to achieve the expectations that the world will expect in the new travel, in the new normal. Because I feel that, you know, before COVID, when one would get on the plane and travel to unique places, in the new normal, there would be certain expectations, including, for example, the vaccine passport, the availability of bellwether-capable facilities, close to where the destinations may be, and I think this is something that development partners and development banks that are listening today would. I would suggest that these would be places where they could be able to support us with small island development stages, making sure that we have stronger health systems in terms of universal health coverage, ability to be able to develop, have bellwether capable facilities in places where we don't have it, so that we are not struggling when the borders do open. And not only are we meeting the needs internally, but we also being able to support our nation in our economic recoveries. Thank you.
Thank you, Minister. And I'd be interested to hear from Papua New Guinea whether they got any thinking, and Benjamin or Iko, if you're on the line, your thoughts on what the Minister just commented on.
Yeah, am I on?
Yes.
Okay, so I'll just unmute myself. So I have to be real at the moment now, partly because of the COVID, but because we have, for the most part, been having difficulties implementing a lot of our programs due to funding, rundown facilities, broken down supply chain systems. And it's difficult for me to say something about a step forward. I'm just struggling where I'm stepping. For example, this year we've had a health budget cut by 79 million, which is tremendous. And just before this conference, my CEO called me up to tell me that we're actually closing down next week. And I'm in one of the regional hospitals in the country. Having said that, we still have to plan forward and move forward and develop the capabilities we need to develop and be strong, trying to get really a fracturing health system back in place, a demoralized staff on board for a dream that looks quite unachievable in the near future. But having said that, we have in the country a new national plan that's coming up, and we've been trying as much as possible to get some of our surgical burden on the list, and as part of this global efforts in surgical care. And I think our training programs are good, and we've got sort of soldiers throughout the country. We've got a health system that's really set up nicely, just needs to be more effective. We need to have a good referral system, a pathway that comes through, and we need to maintain training. And like my colleague from Fiji said, I agree totally that our rural facilities may need to come to a position where we can do some of those bellwether procedures. But I think our road networks, especially up in the highlands, is a bit okay. You can get 2 hours travel into a main hospital. But our coastal region with isolated islands are a bit difficult. And they should have a pathway that should be able to help them effectively referring patients from early intervention, particularly. We're not really good at late intervention because we don't have the resources and everything else we need. And we know our deficiency, we know our weakness, we know how to address those locally. And of course, with partnership from around the globe and a lot of us, our partners, like I said, JICA for equipment and all that, we can achieve a lot of those. I can honestly say the political leadership is not there. And it's almost, you know, not a new, good news and nothing new, but we've got good people in there, and people are trying to help us. They say they want to help us, but of course the priorities are always, political priorities are always changing. So it's difficult. Every now and then people come and say something and it changes. But that's it from us.
Thank you, Benjamin. Lubna, if I can just get one more person to speak from the region, and then I think we should give it to you to look at the other side. I'd like to ask Lord Tangi to make some commentary, who has been at the political level as Deputy Prime Minister with the World Health Assembly and the executive level, the procurement of funding, the difficulties around that. Bill, you have 1 minute. No, Bill, the floor is yours, please. If you can make some comment on what you've heard so far and where that may apply for future financing.
Would you like me to take over from here?
Yes, you take over. You go.
Okay, I'd just like to open the floor to a couple of questions on the Q&A portal. The first one, I'm going to request Dr. Kee Park to address. Kee, if you're ready, the question is from Bistra Zerlieva. I'd love to hear about examples for specialty and subspecialty surgical services, especially those that are unaffordable by the general population with out-of-pocket payments and are considered unprofitable by many hospitals. How should we finance those? Congenital heart surgery is one of those. And we are marking World Birth Defects Day today. So that's a very timely question. Kee, would you like to respond to that?
Yeah, Lubna, I was actually clicking on the Q&A to actually type an answer, but I somehow clicked an answer, said I will answer live. So I get some mic time. But yeah, actually, I do have an answer for that, Bistra. I know Bistra, and she works with cardiac surgery, congenital heart surgery, very expensive operation. Now, I can tell you this, I don't have direct experience with heart surgery, but transplant surgery, which is also very expensive. Philippines, and I don't know if Peter Crowley could answer after me if he likes, but Philippines was able to add transplant surgery to their national health plan, PhilHealth, because of the revenues that they generated in Syntax. So there are pathways to include expensive items through social insurance schemes and increasing physical space. Thank you.
Thanks, Kee. That was a useful and brief answer. And we have another question from Virginia Wang. It is certainly very important to explore all available sources of financing for improvements in access to safe SOTA care, including the private sector, as Dr. Wibbenhorst mentioned. However, private investment firms are motivated to generate profit for their shareholders. And usually these shareholders and the actual stakeholders on the ground are not the same people. So the incentives may not be aligned. I wonder what the resulting financial, ethical, and system implications are, and how we can ensure that already vulnerable groups are not further disadvantaged. Is there anyone who would like to try and answer that? Or I could request.
I'm happy to jump in on this one, Dr. Samad.
Great, thank you.
So Virginia, I think you ask a very important question. And I think you're absolutely right. There's going to be, if we look at the entire investment universe, there are certainly a number of stakeholders who will not be directly aligned. The opportunity before us as part of the global surgery, obstetric, and anesthetic communities, how do we narrow in on the group who are aligned in this? And the alignment comes from a few potential sources. And some of that is quite direct. At the largest level, I know we were part of a discussion with a gentleman called Hiro Mizuno-san, who is the former CIO of the Government Pension Investment Fund in Japan. So they're the world's largest asset owner with $1.6 trillion US. And his point was simple. As an institution which owns that much of the global market, cutting a corner in one area, whether it's on climate change or another area, ultimately hits them elsewhere. And particularly now with the pandemic, what we're seeing is these underinvestments in capacity and health are ultimately stemming long-term economic growth, right? Which I think Dr. Alkire did a wonderful job of elaborating on in his sort of macro analysis of this. So that at a high level is when you deal with these large universal asset owners, large pension funds, insurance companies who we often deal with. The next level, though, is now diving into the micro at the actual investment level. This is where it becomes very important to align incentives to address for exactly what you're talking about. What we've seen, building on some of the social health insurance programs in the region, so in Indonesia, for example, the BPJS program, Australia with Medicare, India with Ayushman Bharat, and these are just some select examples in our region, these provide valuable examples to work in together with these organizations, where the financial investment and the ability to deliver returns is actually driven by being able to improve healthcare outcomes, right, under the outcomes-based financing model. And that by no means is the only way of financing these projects. There are many other permutations. And that comes down to the actual contractual structuring, the outcome measurement, baseline evaluation process. And we spend a lot of time doing that to solve for exactly that risk you're talking about. So for example, in the project in India and Indonesia, the outcomes we are targeting there are decreasing costs through improving health outcomes in diabetes, hypertension, stroke, as well as avoidable cesarean sections, right, which are arising out of preeclampsia and other such sort of preventable early conditions. It also touches actually on the other question that was raised about that whole continuum of care, Dr. Samarth, right, with that challenge of, okay, how do we just stop focusing on primary and also filter this back up to secondary, tertiary? Because in this way, you're aligning interests of the entire system as a whole and health stakeholders within that. In a value-based care model, we are able to shift away from saying we're just going to fund inputs to saying we are funding for the outputs. And that's a fundamental paradigm shift in thinking, because it means we're not just saying, okay, I'm going to put X many nurses in this area to do this. Of course, there's a budget attached to this, but we're saying, hey, if I'm optimizing to improve health outcomes in these select areas, then that paradigm flips, because now the freedom is given to the implementation partner to actually think about what are the best ways to deliver that across that continuum of care from primary through to tertiary. And so these are ways that if we think quite diligently about the actual structures of these arrangements and partnerships, that can be key in ensuring that alignment and ultimately, most importantly, improving access for people who need it most in an equitable way.
Thank you. So another question from our audience today, from Dr. Leodoro. Can we create a focal point or single request mechanism for country applications? For example, primary health facilities, with regards to primary health facilities, workforce training and strengthening existing services. And this is directed at all the panelists. So.
I can take that on briefly. I think it's a terrific idea. One of the problems is, well, there are a couple of issues. One is that there are a diversity of mechanisms, and especially when we're looking at country applications. By that, I mean that, say, the government of Nepal or some other government entity or parastatal is making an application for grant funding. There are certain sort of legal requirements that go along with that. And so therefore, the types of granting arrangements vary by who's requesting the grant. Typically, for USAID, for example, if the grant is going to be to a foreign government or to a parastatal, that's called a bilateral agreement. And those have a very specific set of, as I was saying, legal requirements and fiduciary requirements and so on and so forth. So while it would be great to have a focal point, you have a diversity of agencies and organizations that use different mechanisms to accomplish their work. As far as the question of primary health facilities, that's versus workforce training and health system strengthening, that's a very interesting question, because what you find, I think, is that you look at, for example, what our colleagues in Koika and Jacka were discussing. For example, USAID really doesn't fund a lot of infrastructure improvement. It's mostly funding partners on the ground to carry out either the provision of healthcare or education or training. And with COVID, of course, changed that. But so I think that what it's, the challenge really is understanding what each of the different funding agencies do. And it would be a great idea to have a central clearinghouse of funders and what they fund and why. So I'll hand the question off to somebody else at this point.
Stephanie, can you take the question?
Yeah, I mean, I agree with what Monique said. We should be, as development partners, working towards better coordination and less burden on countries and less burden on partners. And we have to do that simultaneously with all the safeguards that Monique described around the use of taxpayer dollars in overseas development assistance budgets. It presents us with an ongoing conflict in every decision we make about which one wins out every time. But I think it is something that countries and implementers should continue to press development partners on, and not let us forget that actually the fragmented development landscape can create so much inefficiency. It runs counter to our collective goals. So I guess, yeah, I mean, that's my message. We should keep the pedal on any opportunity to drive better coordinated assistance in the development architecture.
So Peter, how does that, Peter Cowley, how does that fit into the collaborating centres for WHO as it applies to training, research or application across the spectrum of activities?
Thank you. Can you just repeat the question? It was a follow-on. I want to make sure I understood it correctly.
So we're talking about people request mechanisms for country, looking at primary healthcare facilities, workforce training, strengthening existing services. Some of those fall into the collaborating centres that WHO has. You got any commentary around that?
It's, part of it is, it goes to the fragmentation issue, unfortunately, and, something I'd just like to comment on. And, we're looking at surgery, but, it's human resources goes across everything. Primary healthcare goes across everything. Logistics goes across every intervention. And, sometimes we, because of our passion or because of what it is we do, we concentrate on one thing. But a lot of what we do, with our collaborating centers is around human resource strengthening, whatever it may be, pre-service training, it may be an accreditation, it may be in licensure. It's across all cadres of workers. So we do have collaboration, but it tends to be on what was formerly known as building blocks. But it's easier just to say it's across different interventions, because we're looking at surgery here, but the way we look at it, it's human resource. And if you're going to do licensure strengthening, you're going to do it based on it's a nurse or it's a physician's assistant, not that it's surgery specific. And that is something we do with collaborating centers. We do have different types of collaborating center agreements. Some are just disease focused, for example. We'll have them on immunization, or on measles, we'll have them on hepatitis, we'll have them on surgery. But generally speaking, they will be more clinically focused, or they could be more focused around what policies. For example, we have collaborating centers around health financing. So some will be around social health insurance. How do you roll out social health insurance, and what could other countries learn from you? But we occasionally have them on disease as well. We have them on hepatitis. And then we have, I believe, a few on essential surgery. But it would not be essential surgery and human resource. It would be essential surgery more the clinical side or the setup of essential surgery programs. And it would be human resource, but across a wide range of interventions. I'd just like to comment, it was a previous speaker had spoken a little bit earlier about potential funding sources. And again, I'd like to return to this theme, and the Minister of Health in Fiji had described his challenges, which I can imagine are intense. Unfortunately, the drop in government revenue in Fiji is astounding. It's main source of revenue has just ceased. And these are very challenging times. I stressed this earlier in the presentation, and something I would like my fellow panelists to comment on is that as well as investments have come in health, but they've been for COVID-19, and not even necessarily for health in COVID-19. For most regions of the world, the investments in COVID-19 have been in macroeconomic stabilization. They've been in making sure that the liquidity markets are open, making sure that small businesses don't go under, making sure that people have something to eat. Health is pretty far down the list usually, especially in higher income countries. In the Pacific, a lot of the investments in combating COVID-19 have been in the health sector. So this dilemma it's going to be limited, but it's going to go on for this year, this fiscal year, and deep into next fiscal year. So what do we do now we need investments in central surgery when it's the actual supply of money is not there right now. And something that would like fellow panelists to comment on is the investments have been in COVID-19. They've been in respirators. They've been in training, for intensive care nurses, again, in preparation for spread of COVID-19. And how much leveraging has been done off of that in the surgery space? I don't know, but it would seem to me, I've seen a lot of these multilateral bank loans, and they're, like I mentioned earlier, huge numbers of respirators, huge, mechanical respiration that have gone out and are going to ultimately be paid for by member states because they're loans. So I'm wondering, is there movement in leveraging off of these investments for COVID-19 for surgery? Over.
Who wants to take that on? Blake, is there any useful outcome in doing all this? You gave us a forward sort of macro economics and things about predictors and so on, but what is actually a useful measure that will make any difference to what we're trying to do?
Well, I know that Dr. Webenhorst had something to say, and I don't want to take somebody's time who has way more expertise, but I'd be happy to circle back to that. But let me turn it to Dr. Webenhorst.
Okay.
Dr. Blake, I'll defer to you, but I just want to make a point as a clinician, and I so much value people like yourselves that have the macroeconomic and other expertise. When we were in the ventilator business and in the oxygen business before I left USAID, we spent a lot of time thinking about this issue because the urgency of the pandemic really there was intense pressure to make it all about the short game, which is how do we provide care for acutely ill patients with COVID-19. But as we were sort of thinking the strategy out, and this came up as a question, I think, in the chat, the provision of ventilators is not a bad thing because a ventilator, at least my understanding, is the ventilators that that were being provided under not through a loan program, but a straight up gift, were ventilators that could be used in the OR as well. And so one of the principal limitations, as we're all very, very keenly aware, is anesthesia care. So now you've got an opportunity to leverage those investments in critical care training, in ongoing mentorship for anesthesiologists, in ventilators, and in oxygen to try to at least improve from the capacity side the ability to do safe surgery. Obviously, it doesn't fill in everything, but that was a really big part of the thinking, is that we want to at least try to play for the mid and the long game here, which is to strengthen systems above and beyond the acute COVID response, to strengthen systems long term to be able to increase their critical care and surgical capacity. And that's where I see that coming in, that health system strengthening piece coming in, is to make give facilities the ability to safely and appropriately mechanically ventilate people, whether it's in the OR, whether it's in the ICU, whether it's a child whether it's a mother that you have a failed spinal that you need to do an emergency cesarean section, or whatever you're going to be using it for. So just wanted to bring that up. Thanks.
And so I understand the question. It's how do we think about assessment or metrics in the context of the macroeconomic impact that supplying COVID-19 health financing to deliver ventilators, for example, how can we either think about leveraging that or assessing that? Is that the question? Yeah. Well, I would say that, for me, this has been actually one of the most enlightening parts about this discussion is sort of thinking about how we begin to address what I think has long been the elephant in the room in global health, which is that health system strengthening is unbelievably hard. It's a buzzword, but it is, when it comes to brass tacks, I would argue that there are really few donors, both NGOs and governments, who really have the patience to invest meaningfully in health system strengthening. Of course, we all understand why outcome assessments are important. We need to be able to measure what we're doing to make sure we're actually doing good. But at the same time, short-term and medium-term outcomes assessments often are incentivized away from a truly robust investment in a horizontal health system strengthening, which surgery requires. So when I was thinking about the COVID-19 discussion, a lot of actually the elements that are being put into place, the ventilators, critical care training, that's an essential core component of surgical and health system strengthening. And so if one wanted to think about it from a macroeconomic perspective, you could start to make the case that not the short-term investment, saving lives, both in terms of productivity and labor supply, should have a meaningful outcome in terms of potential GDP. But you could really start to think about economies of scale and start to think about the fact that that initial investment for COVID-19 could actually turn into provide much greater returns because those ventilators are not going to just be used for COVID-19. The critical care nurses are not going to be just used for COVID-19. And so there are a number of ways that actually you could go about estimating both the impact on COVID-19 with regard to GDP, but also sort of a broader approach that begins to model the impact of a true critical care health infrastructure on a country's well-being, either in terms of economic output or total economic welfare.
Thank you, Blake. Dr. Lubna, I'll let you take us over the line.
We do have a last question, if I can call it the last question, that was put in a while earlier, directed at Monique, and maybe we take that as a last, audience question for the day, and we then do a very quick wrap up. If we can keep the response to this to a couple of minutes, that would be great. It's directed at Monique, I think. Monique Wobenhurst recognized a trend towards increased provision of care by the private sector in LMICs. What is the implication of this trend? And the question goes on to talk about, is this perhaps an additional motivation to improve public health care and focus on UHC through national insurance schemes? Monique, would you like to respond to that?
Sure, absolutely, and I'll keep it brief. I think this is an extremely important question, because I do think that there is a view that universal health coverage and improving the public healthcare system is going to be the solution. I would have to say that up until the present, I don't take that point of view. I think that it's probably a mixture of both public, private, and voluntary sector that is able to care for all segments of society. The trend is not, it's just, I was recognizing the trend.
I think we've lost Monique. Until we get her back, is there anyone else who'd like to comment on that?
Lubna, while there's a gap, I might just ask Annette Hollian to make a comment as part of one of the main partners from the Royal College of the Australasian College of Surgeons. Annette, some thoughts from you on where we got to in process?
Not as regards funding. The programs through through RACS are very heavily dependent on DFAT funding us for specifically the Pacific Islands program and the CSP in PNG. We've been doing a lot. We've really tried to focus hard on the coordinated capacity building, but the last year has been difficult because we couldn't have our traditional visiting medical teams travel, but it's also revolutionary because we're able to address things in a new way, that we're really being able to focus on what it will look like going forward rather than looking back. Tremendous work that's been done in the past, and I see a lot of familiar faces on here that have been related to RACS and people who've been scholars that are on the panel. And we'll continue to work as we go forward with the nations, developing what's needed in the nations. And thank you for the leadership they've shown and helped redirect our energies.
Dr. Lubna.
Thank you so much for that. And I think with 2 minutes to the hour, and I know there are many people who want to get to work or to bed, depending on which time zones we're in, we'd really like to wrap up the webinar for today. And I think it's a recognition that financing for healthcare in general, but surgical care in particular, is challenging and complex at best. And although this webinar can never aim or aspire to provide any solutions or package solutions for the really diverse range of problems and realities that people in different regions and different countries, and even within countries, different settings face. It does, however, start a conversation and highlight the many possible ways in which this problem can be approached and navigated successfully. And I think my thanks to the organizers of the session. I know that while Key has taken a lead, there's been this amazing team who has been coordinating behind the scenes. I won't take any names because I'm going to miss someone and I don't want to do that. But it has been an amazing teamwork at the back end, coordinating, getting the speakers to, the scope of discussions we've generated today is to a large part because of the amazing panelists we've had, and getting each one of them to come on board and stay connected for these 2 hours. I hope the participants have enjoyed this as much as we have, and we're very grateful to, I think we hit almost 150 participants during the course of this webinar, which is no small feat in itself. So thank you so much to the team who managed to put this together, and we'll look forward to seeing more, all of you and more at the 3rd webinar in this series 2 weeks from now. Thank you so much.
Thank you both also to Lubna and Kiki for amazing moderation. And we wouldn't be closing unless we take a group picture. So can everyone turn on their cameras and smile? And we will take some pictures. Great. Thank you, everyone.
Thank you. Bye-bye.
Thank you. Bye-bye. Bye-bye.